All right. So for you, Xander, what makes EMR difficult?
But first difficulty is, like was previously discussed, the planning ahead. That you need to plan a map in your head. First, what pieces do you want to take, in which order do you?
Well, let me stop you. You're looking at a polyp.
Yeah.
What makes it easy or difficult? So I agree with everything you just said, but that's not my question.
Okay. Well, the accessibility first, where it is in the colon, how accessible it is, if it's behind the fold, on a fold, right in front.
Fantastic. Everything great. Okay, Lynn.
Yeah, I think indeed a polyp in a difficult position. I was thinking of hepatic flexure, sigmoid.
So subtly different from his because he's talking about access. So I think there's two things in access. Getting there with the scope can be difficult, and the actual positioning of the thing on a fold, difficult to position the scope, often related to one. You're talking about recognized difficult locations in the colon, right? Like what, ileocecal valve, you said?
Yeah.
Hepatic flexure. So any flexure, sigmoid?
Sometimes.
Okay, yeah. Diverticular disease, maybe. Anal rectal junction, maybe. Appendiceal orifice. Yeah, so I think those are they. Okay, any idea, any other things that make polyp, like a polyp, what makes it more difficult? The same polyp in a different situation.
Flat polyps.
Yeah, flat, like, so totally flat. And by that, I think we mean sessile versus pedunculated. Maybe that's one way, because pedunculated, I think we generally recognize we're not talking about, and is easy. There are some facets to pedunculated polypectomy, which we won't cover today, but in general, pedunculated polypectomy is easier than sessile polypectomy. Yeah, okay. Celine? It's getting more difficult because we're going to come back to Xander in a minute, and it's going to be very difficult.
The size of the polyp.
Yeah, sure. The size definitely has an impact. And if it is 100 versus 10, then obviously it's more difficult. Sure. Maria Eva, have you got a difficulty?
Said before, the previous attempt.
Yeah, non-lifting. And what we mean by non-lifting is fibrosis in the submucosal layer, which means that you cannot inject and get it either to come towards you, manipulate it, make a nice snare position, get a good snare capture. So some great ideas there. I want to give you a system for identifying what makes polyps difficult to resect. I want to show you how to identify them before you start, because I think it is critical to have this discussion with yourself. Usually it's with yourself before you start, because the problem is if you have the discussion with yourself in the middle of the procedure, what happens is like what's happened in this case, where this person has started a polypectomy and realized during the middle that they can't finish it. And you want to avoid that, because that has a negative impact on patients in the end of the day. And yeah, show you some possibilities. So what makes bad news for patients in EMR? Well, starting and not being able to finish, doing piecemeal when you should have done en bloc, and trying to do any sort of endoscopic resection to a deeply submucosally invasive cancer. And why these things have negative impacts on patients should be obvious to you, but we can go through them shortly. So why might that happen? Why might you start something and not be able to finish it? It might be because you're not honest with yourself about your level of competency at EMR. It may be that you just didn't think about it before you start the procedure. It may be that you encounter an adverse event which prevents you completing the procedure because you are either unable to handle it, or you think that maybe it's not something that could be handled. Right. So we were talking about difficult polyps. So the appendiceal orifice. Yeah, look, are you going to stay with us in here so we can talk about some of these things? Is that all right? Here, you can see the appearance later on. You can see that this lesion came right down and involves the orifice, but actually when we completely removed it, usually if you can see a border here, you can completely remove it with the MR. And so that was the case here, and you can see it completely removed at the end. Special cases when the patient has had an appendicectomy. At that point, you can remove something that looks like this with no problem. because there's just fibrosis underneath. And considering the above will make patients better. And it will also help you in your department train. Like if you're into training and that's what you want to do, then you can use this to plan training, and you can use it to do your departmental planning.